Recording.
Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ again. So this is going to be our free 2-week sessions from tonight. So I hope you guys have got the schedules of our free 2 sessions, and we are planning to do few important classes with you this time. So most of you, I'm sure you have joined our psychiatry trial session that was on 27th of July. And then today we are going to mainly just go through some of the questions and give you an idea that how the questions can appear in your exam and what could be the tricks and what are the traps in the exam. So it's important to know that how questions come in exams so that you can start your preparation. Sometimes in questions, most of the things are actually for you to understand what should be the answer. But sometimes they include some things which are actually just for trap, for you to get confused. So it's important to understand what's in the question that going to help you to solve this question and what might be the trap or what can like make you confused in the exam. So today we are going to give you some idea about it. And then you are going to get some cardiology classes, which are super important. And also you'll get 2 question solve classes as well. So we have asked 2 of our mentors to take those question solve class with you so that you get some idea about those sessions as well. Okay. So 2 weeks free sessions is more than enough for you to understand that how we take our sessions. But I'm sure that if you are part of our Facebook group, you must know that like everyone you must have read about everyone's feedback about the course. So definitely, I'm sure that there is an idea in your head that how the course is going to be. But again, we offer these classes just for you to understand how we mainly teach you in the course, what we follow in the course, and what you can do to improve yourself to pass this exam in the shortest possible time. Okay? All right, so let's start our session. Now, in question solve classes, there is no syllabus. We discuss everything. Unlike the theory sessions where we focus on a particular thing, like when we did the psychiatry, we just did psychiatry, nothing else. When you do your cardiology, only cardiology will be discussed. But in question solve classes, everything comes and we try to discuss everything. So this becomes vast, and initially everyone struggled to do these classes is because many of you don't have any idea about these topics that's come in exam. But over time, when you start your preparation, when you finish at least 2 months with us, then these question solve classes will start to become easier for you. Okay, moving on, we are moving on to our first question for today, and we will give you a break after an hour, and then we will discuss a little bit about the course, and then we will restart the class again. All right, so that will be the plan for today, and any class that we take is for 2 hours. So just make sure that you are well prepared for it. If you have any questions about the course, feel free to ask it during that time when we discuss about the course, okay? But now it's all about class. Moving on. So today's class is about tips and tricks of question solve. First question for today. So you have got a 23-year-old motocross rider is brought to the emergency department following an accident. There is a 6 centimeter laceration over the anterior aspect of his tibia, which is clearly deformed. His foot is well perfused. Which one of the following is the most appropriate initial step in management? So many times you will come across to this kind of questions where they give you like questions related to orthopedics, especially fracture, and they ask you what will be your next step. So it's a good thing to understand the step-by-step management for open fracture and closed fracture. So tell me, what do you think? That is there any fracture in here? So many of you think there is no fracture here. There is fracture, right? So you can see that they would not just say that there is a fracture. The exam questions are not always that easy, but you need to understand. So in here you can see that there is a laceration, and then the tibia is clearly deformed. So if a patient comes to you after a motor vehicle accident and there is an open wound, and you can see, or you can at least find out that the bone is not straight, which means bone is deformed. That means, yes, it is a fracture and it is an open fracture. Okay? So now we have established that this is an open fracture. When we get an open fracture, the first thing that we look at, what do you think what we should look at when there is an open fracture like this? Guys? No, I'm not asking about the question answer. We will go into that one by one. How we say it is an open fracture? Because there is a laceration. So when there is a laceration, means that it is open. And if you can see through that laceration that the tibia is clearly deformed, that means it is open. Otherwise, you couldn't see that. Yes, very good. So when you get something like this, the first thing that you look at, if there is any compromise of the neurovascular status. So you check the pulse, you check if there is any neurological compromise. That's the first thing that we would look for. Now let's say, in here they say the foot is well perfused, which means that the patient actually has good pulse. So that is good. Now, if they would say the pulse is not felt, or there is lack of perfusion in the distal part of the fracture, what would you do next? Reduction. Brilliant. So very good, Davy King. So if there is a neurovascular compromise after a fracture, our first step is to do the reduction, because without reduction, there will be pressure on the nerves or vessels, and this ischemic process will be ongoing. So this comes in exam also sometimes, where they say that there is an open fracture and there is no pulse there is no distal pulse. So when that happens, your first step should be reduction. Now, any fracture, anything that is painful, if it comes in exam, and if there is an option of choosing analgesics, we would always choose that. Okay, so if there is an option where patient comes to you with any kind of pain, and like in the questions, motor vehicle accident, any kind of injury, patient will be in a lot of pain. And if in the option you see that there is a option, they said offer analgesics or give IV fentanyl, IV morphine, something like that, that is always our first option. Because even before reduction, even before doing anything, you would actually give pain relief to this patient in the real life scenario. Isn't it right, guys? Because that is how we would do. So the first thing for any injury patient is making sure the patient is pain-free. All right. So look for those options in the exam, because in exam, sometimes many of you are well oriented to the fact that if you just do some questions or a Q bank, the questions will just come in the exam and you will pass just by looking at that question. That is a very, very vulnerable and dangerous idea. So people say to you that no, just do 6 months questions, 6 months Q bank, and then you will pass this exam. This is not right at all. In exam, you might get like some of the topics might get common. So topics like fracture will come in the exam, but they will always change your option. They will change the question. So if you don't have a good basic, doesn't matter whether you do 12 months, 2-year question solve. If you have done all those Amidex, M plus X, or whatever QBank is there, doesn't matter. You will not pass the exam. The main idea is always to get a good basic and understand what you would do step by step to pass this exam. And that's what we normally try to establish in the course, so that you just don't memorize questions, because memorizing question is the first cause of failing the exam. Okay? All right. So now this question, so what we think that for this question, we don't have any analgesics. The patient's neurovascular status is good. So we don't need to just do the fracture reduction just yet. We can do few things before we do that. So we have an option of IV antibiotic. We have option of lavage, surgical debridement, and tetanus toxoid. So many of your options was IV antibiotic, and there was option of surgical debridement. There is option of lavage and tetanus toxoid. So you are actually with everything. Let's go through a discussion about it, and then we will come back. So this is one of the guidelines that we would follow for this kind of question. So NCBI. So most of the time, the guideline that we follow should be Australian guideline. But sometimes this kind of fracture management are not very well written in Australian guideline. So then we go through like NCBI, or like NCBI is good. Sometimes some of the journals or articles are very well written, but most of the time, if you are looking for answer of some questions, especially medicine related questions, you would go to RACGP to look for answer. I will show you how to search everything and how to get the answer from a particular article. So first of all, let's read a little bit from here. So you can see how the open fracture looks like. And these are actually high chance of contamination and getting infected. The guiding specific principle, so the guiding specific principle in the management of open fracture is the prevention of infection. Okay, the presence of a wound implies contamination but not primary infection. It is the key to treatment to prevent this contamination becoming established infection. Because just because there is an open wound doesn't mean that infection has already happened, but there is a high risk wound to get infected. So definitely you will need to do something to prevent it. So how we are going to assess a patient who has this kind of major trauma? All patients presenting after major trauma should be fully assessed following a system such as ATLS, which ensures, so this is not needed for you. So any patient who has a major trauma, we follow the primary and secondary survey. Primary survey mainly include checking the airway, breathing, circulation, and secondary survey looks for the whole body to look for any kind of injury. So after you have done the primary and secondary survey, and that's for any kind of major trauma patient, then you look at this specific fracture area. The limb should be assessed for signs of fracture and the severity of the wound assessed visually. Distal neurovascular function should be assessed. So when we do the secondary survey, we would check all the extremities, and definitely we will check for any kind of fracture and also the severity of the wound. Then we check the neurovascular status. Gross contamination may be removed but probing the wound, attempts at debridement in the ED should not be done. See? So you can remove a little bit of like gross contamination, but do not just attempt debridement in the emergency department because this will be done in the operation theater. A primary photograph of the wound is very useful and should be taken if possible, and the wound should be covered with a sterile dressing. The fracture should be grossly realigned and the limb splintered. The tetanus and antibiotics should be given urgently. It is accepted that earlier the antibiotics are given, the better, but it must be emphasized that this is an adjunct to surgical treatment, does not provide an increased window allowing surgical treatment to be delayed. Okay? So what we have done, so we have checked the limb, we make sure if there is any fracture or not. Then we check for any open wound. If there is an open wound and a fracture, we check the neurovascular compromise. After that, if there is no neurovascular compromise, then we go for antibiotics. We give some tetanus injection if needed, and then we send the patient to the operation theater. So patient should be taken promptly to the OT for adequate wound assessment, debridement, and lavage. So lavage is not the first. Okay, and there are lots of other things which you can go through in your own time, but that's the main thing that I wanted to discuss with you from this topic. Okay, so for these questions, our next step should be IV antibiotics. Fracture reduction would be the first option if this patient's neurovascular status was compromised. Lavage and surgical debridement should be done in the OT. And tetanus should be done after antibiotic if the patient tetanus status is not adequate, which means if the last tetanus was given less than 5 years ago, then we can go for a tetanus vaccination as well. So that's your answer in this case. Any question, guys? If no pulse and severe pain, what to do? So main thing is that if there is any analgesics in the option, then that's the first option. If there is no analgesics, if you can't get the pulse, reduction should be the next step. Okay, because the patient can lose the limb if the neurovascular compromise continues. Okay. Doesn't matter. We can easily look into the patient's immunization register, Dr. Saba. In Australia, everyone's immunization status can be seen by online. So we can definitely find out even if the patient can't remember. Okay, moving on to our next topic. Now, one other thing that sometimes in your exam, you will find out that different kind of pattern of questions. The pattern of questions will be, sometimes they ask, what is the next step of management? What is the initial management? What is the next most appropriate management or step? Remember, management include both investigation and management. Okay, so if you need to do investigation first, that's also a management part. So next step, initial step, next most appropriate. What is your next best step? All of these are same. So if there is a next most appropriate, next step, initial step, next best, everything is what is your next step or what is your initial step. Okay, not the definitive steps. When they ask you the definitive one, they would say, what's your most appropriate step in this case? What's the definitive management for this patient? Okay, for someone who has a fracture, the definitive management is fracture management, right? So if we need to put a plate or a nail, that's the most appropriate or the best management. Okay, but before that definitive step, we have a lot of other things to be done. So in your exam, you also need to understand what type of questions they are asking. Because depending on the questions, your answer can be different. Okay? Moving on to our next step. So the other thing about these question solve classes is to become just oriented to that particular topic, because these topics are discussed in the classes, like in the theory sessions, we discuss this topic in detail. So when we do a particular question solve classes, we try to just focus on that particular questions and getting an understanding about that question, not discussing the full theory on a question solve class, because in that way, we might be just able to do 10 questions with you, which eventually doesn't give us any kind of like best outcome from that particular class. Okay, so if we go for just one questions and we just discuss fracture the whole night, what will happen that we can't go further. So these classes, especially these topics, are very important, and those questions, like if you have any other questions related to fracture, that will be discussed in our orthopedics class. Okay, so let's skip for that and we go forward. And Dr. Shahida, it is an open wound. We remember that just because we are choosing antibiotic doesn't mean that we would not do debridement. So it's always about the next step. The debridement and lavage, according to our discussion, it has to be done in the operation theater. So step-by-step management is always important. People think that, well, I choose IV antibiotic, that means I would not do anything else for this patient. That's not the case, okay? So without laceration or open wound, there is no need of antibiotic, okay? And is there a risk of worsening neurovascular compromise? No. Blind reduction, like that's not actually the case. We do blind or closed reduction all the time, okay? So closed reduction is very commonly done. And we don't need to see what we are doing for those kind of reduction, right? The main thing is that if you don't do the reduction, by that time, the neurovascular compromise will just continue. So it is totally fine to do the reduction if there is a need of it. So if not lacerated, then you might just want to give them analgesics and put a splint on that so that the patient doesn't move the limb. So in that way. So for those cases, until if it is not an open wound, then there is no indication of giving tetanus or antibiotic. Okay, so the management will become just a simple fracture management. Okay, let's move on, guys. Diabetic patient with ulcer on the right foot, 2 deep ulcers at the medial malleolus and foot with skin necrosis and inflammation. Glycated hemoglobin is 6.5. He was admitted and antibiotic was given. Taken swabs, sent for culture sensitivity. What will you do after that? So diabetic foot ulcer is a super important question for exam. So you have got a diabetic patient with ulcer on the right foot. And the foot is looking like that. Okay, so you've got a diabetic foot ulcer and 2 deep ulcer at the medial malleolus and foot with skin necrosis and inflammation. The diabetes is not really bad because HbA1c 6.5 means that it is well-controlled diabetes. He was admitted and antibiotic was given and taken swabs, sent for CS. So what will you do next? Now, in exam questions, when they give you a diabetic foot ulcer and they talk about necrosis, like skin necrosis, and if they say, because in exam the questions are much elaborated and they include most of the important things, but sometimes when we do the question solve, the questions are not complete enough sometimes, so it can become confusing as well. Now, the main thing to understand from diabetic foot ulcer is that what is the most important complication that you would need to look for in such ulcerated wound? Osteomyelitis. Very good. Because deep-seated ulcer are very common in diabetic ulcer, and especially if it is a non-healing ulcer. So we need to make sure that if it is a non-healing ulcer, if it is skin necrosis started to happen, we need to make sure that there is no bone involvement, which is osteomyelitis. Now, there is an option of X-ray, MRI, bone scan. The question is, what will you do after that? So after taking a swab and antibiotic, what's your next step? Okay. Now, before we answer these questions, I will go and discuss the diabetic foot infection and then we'll come back. Okay. So a stage of diabetic foot infection, so mild means that if there is just a local infection involving only the skin and subcutaneous tissue, without any involvement of the deeper tissue, no systemic inflammatory response. That means no fever, no nausea, vomiting, no tachycardia, and the redness around the wound is less than 2 centimeters. So mild means just localized infection involving the skin and subcutaneous tissue, no systemic response, and also the redness around the wound is less than 2 centimeters. Moderate when the infection starts to get bigger with erythema around the wound more than 2 centimeters, and it starts to involve the deeper structure. That's the time you would think of osteomyelitis, septic arthritis, those things. But still there is no sign of systemic response. Severe means when there will be systemic inflammatory response. Okay? That means when patient starts to get the fever, tachycardia, nausea, vomiting, then you would think of systemic inflammatory response. So this is how we know that mild, moderate, and severe diabetic foot ulcer. Now, the main thing that you should remember, if it is a diabetic foot, and patient having a non-healing ulcer for at least 2 weeks, our next investigation is X-ray. The X-ray is mainly to find out if the bone is involved or to get any kind of sign of osteomyelitis. It is very unusual, or it is very hard to get osteomyelitis by a X-ray unless it is severe. But still, as our initial step, this is what we are going to do. If they're asking about the best investigation or most appropriate investigation, that is always MRI or bone scan. Diabetic foot having a yellowish discharge from the wound, that's the time our next step is taking a wound swab, send it for culture sensitivity, then wound toileting, that means clean the wound, debride the wound, and then antibiotic. Now, both of these questions come in exam. In one picture, you would find out that it's clean. There is no discharge like that. In another picture, you would find out there is a lot of yellowish slough or discharge coming out from the wound. So that is the only time when you would take the swab, send it for culture sensitivity, and make sure you do the wound debridement and toileting, and then start the patient with antibiotic. So two different kind of things. What is the choice of antibiotic for diabetic foot infection? If it is a mild infection, you can start with oral antibiotics such as amoxiclav, cefalexin, flucloxacillin, or clindamycin. But most commonly, any of these. Clindamycin is usually if patient is allergic to penicillin or Kefalex. Moderate infection, you will go for IV, so IV augmentin or cefajolin plus metronidazole. Remember, in Australia, very rarely you would use all those strong antibiotic. Okay, so you would not just start a patient with ceftriaxone or cefepime in Australia. So in Australia, most of the initial choice of antibiotic are these. So IV augmentin or cefajolin should be your first step, plus add a metro. If it is severe infection, then it will be a triple antibiotic, which is pip-taz, so piperacillin, tazobactam, and you can add a cipro or clavulanic acid. Okay, so that will be your step-by-step choice of antibiotic for wound infection in a diabetic foot. Have a look on this guideline, how we treat or how we manage a diabetic foot ulcer in Australia. So you have got a diabetic foot ulcer. If it is a non-healing diabetic foot ulcer for at least 2 weeks, and or if you see that bone is visible through the wound, in those situations, you go for a plain X-ray. If the X-ray shows any changes which goes with osteomyelitis, then consider a bone biopsy and then treat the patient as osteomyelitis, which is IV antibiotics. If the X-ray shows no sign of osteomyelitis, then you look, can you visualize the bone through the wound? So bone on view, or can you can sometimes use a probe, and if you insert the probe through the wound and it touches the bone, that means positive probe to bone. If any of this is there, you should be still suspicious of osteomyelitis. So you presume osteomyelitis, consider a bone biopsy and treat as osteomyelitis. But there is no bone on view, no positive probe, but you are still suspicious of osteomyelitis, then you can do a MRI. Okay? So this is what we would do in Australia. If MRI is contraindicated, like patient has maybe a pacemaker, or patient has some other electric, like maybe a cochlear implant where you can't do a MRI, then you would go for nuclear medicine scan or bone scan. Okay? Does it make sense for everyone that what is the step-by-step investigation? So X-ray, MRI, bone scan, that's how we would go for. Now we are going back to our original question. So what do you think you would do in this patient? X-ray, MRI, bone, Doppler, complete blood count. Now, many of you would think about Doppler, but what Doppler would give us in here? Nothing much. But we can do it to know that how is the blood supply. But that's not our first thing that we are worried about in this patient. We are worried more about osteomyelitis. So X-ray should be our next step. Okay. If they say what is the most appropriate step of management for this case, that will be MRI. We need to remember the name of all the antibiotics? Yes. You don't need to remember the dose of antibiotics for AMC, just the name. So positive probe bone is, there is an instrument that you can use. So using that probe, so just write bone probe in Google, you will find out. So using that probe, if you go through the wound and if you can touch the bone, that means it's positive probe bone. The source of this flow chart is an Australian guideline, which is diagnostic imaging pathway. Okay, why not bone scan? We just discussed Dr. Lenovo. So I don't know what's your name. Your name is showing as Lenovo. So that's why, because MRI is the best step in this case. If MRI doesn't show osteomyelitis, then we go for bone scan. A young man working came to the ED with big abscess under his arm. After draining the abscess, what is the investigation of choice? So what you would do after you have drained a big abscess from someone's arm? You start antibiotic, full blood count, own culture, ultrasound of the abscess, CT of the arm. So always remember there is an abscess, you drain it. So draining the abscess is the first thing. When you drain it, you get you get the discharge. So you take a swab and send it for culture. So culture is the next step, followed by antibiotic. Or as an empirical antibiotic to any kind of abscess, what is your choice of antibiotic? Which antibiotic you would prefer for abscess? Flucloxacillin or dicloxacillin, okay, or cefalexin. That's our choice of antibiotic. So for abscess kind like this, flucloxacillin or dicloxacillin, or you would choose cefalexin. Definitely not vancomycin. Never, not at least because after culture, if everything is resistant, then you can think of that. But vancomycin is way out of line, and definitely not ceftriaxone also. So you would start either a Fluclox or you would start with a Keflex. You can use Augmentin also, but because most of these are staph, so Staphylococcus aureus causes this kind of big abscess, and staph is, for staph we normally use Fluclox or Diclox. Okay, but Augmentin can be used as well. But as I say, in exam you will get multiple options, and in the option you will get options which are also your answer. Like at least 2 or 3 options will be your answer. That means they give you Fluclox, then they give you ceftriaxone, let's say, then they give you Augmentin, then they give you clindamycin. Now, Fluclox, Augmentin, clindamycin, all are option and all can be done. In exam, you have to choose the best. What's the best option you have got? So that will be Fluclox. Okay. So understanding the AMC exam is important, and the purpose of our tonight's session is that, because You need to think just what has been asked in the exam, nothing more, nothing less. In exam, you can't think that, well, I want to choose all these three options because I know this is all of them are correct. That will not work. Or some of you think, well, I don't like flu clocks. I want to start augmenting, but I know this is also a correct option. I want to choose augmenting. Doesn't matter what you think, but all that matters is what is the best option out of these five. Okay? So think in that way, the exam will become easier for you. Moving on to a very, like, it's kind of an old question, but everyone needs to have an idea about it for any exam. So a previously fit 55-year-old man has undergone an emergency right hemicolectomy for a perforated cecal carcinoma. 2 days after the operation, you note following on his fluid balance sheet: intravenous input of 2 liter, nasogastric aspiration 2 liter, drain loss 700 ml, urine output 500 ml. Biochemistry shows sodium normal, potassium is bit low, chloride okay, bicarbonate okay. Which of the fluid balance regimens below would you order for the next 24-hour period? So this is called fluid balanced chart or input-output chart after an operation. So very important thing to understand and get the basics. So what we normally do for this kind of cases is to find out what is the total input for this patient and what is the total output for this patient. So in here you can see intravenous input was 2 liter, right? And all of these others are output. So nasogastric aspiration 2 liter, drain loss was 700 ml, urinary output was 500 ml, and for everyone there is a insensible loss from their skin and other areas which you can't measure, but we keep it as 500 ml. Okay, so if you make it a rounded number, so 2 liter, 700 ml, 500 ml, and 500 ml, so 3.7 liter, right? So 3.7 liter, just make it as 4 liter. Up to this, does it make sense, guys? Like how we measured the input and output? Okay, no one needs me to repeat because this is something that we want you to understand step by step so that we don't need to repeat the full thing again. So the input is 2 liter. As we can see from here, the intravenous input was 2 liter. And we're talking about the output. So output means what has come out from the patient's body. So aspiration 2 liter, drain loss was 700 ml, urine output was 500 ml, and then there is the extra 500 ml, which is insensible loss, which you can't actually measure. So we just keep it as 500 ml. So everyone's body like has some kind of fluid loss through the skin and other areas. So we keep it as 500 ml always. So together it becomes, if you do the math, it is 3.7 liter. But for the purpose of the math, we always make it a round number. So 4 liter. Okay, that makes sense. Now, if you see here, the input was 2 liter and output was 4 liter. So how much is the deficit of fluid in this patient? So if you have given 2 liter fluid to a patient and 4 liter came out, how much patient is having deficit? 2 liter, easy math, right? So this 2 liter needs to be added to the maintenance fluid. So that's what's the main purpose of this question. So let's talk about it. So what we do that everyone after in their post-operative period, they get a maintenance fluid. So the maintenance fluid is given in this way: 1 liter normal saline plus 2 liter dextrose plus 20 milli equivalent potassium per liter of fluid that you are going to give to this patient. So that's the maintenance fluid for anyone from the second postoperative day. So 1 liter normal saline, 2 liter dextrose plus 20 milli equivalent of potassium per liter of fluid. Now that is given for everyone. Okay, so this is for anyone even without the deficit. So we know that our patient already has got 2 liter deficit, right? So this 2 liter needs to be added in the maintenance fluid. Where we add it in the normal saline. So now you add another 2 liter. So it becomes 3 liter normal saline and dextrose will be same. So 2 liter dextrose. So how much fluid you have given to this patient now? 5 liter, right? Brilliant. So if you have given 5 liter, how much potassium you have to give? You know that 20 milli equivalent per liter of fluid. So for 1 liter, you give 20 potassium. For 5 liter, 5 into 20 equal to 100. So 100 milli equivalent of potassium. Okay, so that's the answer of this question. So first you find out what is the deficit amount, and then you add the deficit amount in the existing maintenance fluid, and always add it in the normal saline. So 3 liter normal saline, 2 liter dextrose, and just find out how much potassium you need to be added. Okay, nice and easy. Yeah, so deficit amount will be added in normal saline always. And what was the other? Dr. Huda, what is aspiration? Aspiration means taking out. So that is definitely an output. Okay, makes sense for everyone. So now if we go back, so we have got our option D, which is going with everything that we have discussed. 3 liter normal saline, 2 liter dextrose, and 100 milli equivalent of potassium. Any question over here? No, if you give the potassium in this way, potassium should be in the normal range. Dr. Shia, dextrose remains the same. So potassium is 20 milli equivalent of potassium per liter of fluid. So if you in here, you have given 5 liter fluid, right? So they say 20 potassium for 1 liter. So what will be for 5 liter? 5 into 20, that's 100. Now, if potassium goes high, then you will stop the potassium. So it always depends on the potassium level as well. So you measure those electrolyte, but most of the patients, potassium doesn't get high after operation because of loss of potassium through the wound or the surgical area. So most of them are deficient. So it's not usual to get a hyperkalemia in a post-operative patient. But if it happens, then definitely you would not give it. Yes, potassium is not in the first 24 hours, but it is given after 24 hours. For diabetes patient, you would not add the dextrose. Okay, so there are different scenarios for those cases, but it depends on a lot of other factors. Okay, let's move on. Patient comes back from Thailand with history of having sex with multiple prostitutes. After 1 week, patient presents with lymphadenopathy, mild pharyngeal erythema, splenomegaly, sore throat, atypical lymphocytes present, monospot test is negative. What is the diagnosis? So this is also another commonly asked scenario where they give you a patient who comes from overseas and presents with a lot of symptoms, and they ask you what is the most likely cause. And Dr. Souza, no, 500 ml is not adequate. That's why you are adding the fluid, right? Because the reason why the patient's urine is inadequate because patient is having more output rather than input. So patient is dehydrated. So that's why we are giving more fluid to this patient. Okay. All right. Coming back to these questions, have a look that patient came back from Thailand, history of multiple sex with prostitute, after 1 week coming with lymph node enlargement, mild pharyngeal erythema, splenomegaly, sore throat. Atypical lymphocytes are present, but monospot is negative. Do you know where we get monospot positive? Yes, monospot is positive in Epstein-Barr virus. If monospot test is negative, can it be Epstein-Barr virus in any way? Yes, it can be because 20% cases, patient's monospot can be negative, but still patient can have EVV. So just because now this is a trap. So I was talking about trap initially. So this is how the traps are made in the exam so that you fall on that trap. So they say monospot negative, and immediately most of the candidate thinks that no, Epstein-Barr virus cannot be there because this is negative. But in 20% cases, it is still EVV even if monospot is negative. So it's not a specific test. Okay. Now let's find out, because we found a patient who is coming from overseas with sexually transmitted infection is a likely possibility, but it's not always the case. Just because the patient had a sex with multiple prostitute doesn't mean he's going to get HIV all the time. Okay, so lymph node enlargement, mild pharyngeal erythema, splenomegaly, and sore throat. That's our main symptom. I will come back to these questions after this. So let's talk about Epstein-Barr virus, HIV, and CMV. And this is from your John Murtagh, 8th edition. There is a very easy way to differentiate HIV and Epstein-Barr virus just by looking at their symptom. So fever will be there in every infection. Fatigue, malaise is also common. Very common is sore throat and pharyngeal erythema in Epstein-Barr virus. So in Epstein-Barr virus, you definitely get sore throat. Excuse me. So you definitely get sore throat, pharyngeal erythema. You will get exudative pharyngitis. That means If you look on the tonsil, you will see a lot of pus. And tonsil can be enlarged as well. But that is very rare in HIV and CMV. So that's one thing that will help you to diagnose. Next, mucocutaneous ulcer. So oral ulcer is very common in HIV, not very common in others. Jaundice can be found in EVV, not very common in others. Splenomegaly is very common in EVV, 50%, and rare in HIV. Hepatomegaly can be found in EVV, rare in HIV. Lymphadenopathy will be there in everyone. Not that in CMV. Diarrhea common in HIV. Now, if you see from our question, EVV will be the most likely cause if the patient has tonsillar problem and the patient has splenomegaly, okay? And atypical lymphocyte, you can see, can be found in any of them. So that doesn't actually help us to think anything. So if a patient has got mainly lymphadenopathy, splenomegaly, and pharyngeal erythema or sore throat, we will go with EVV. And if a patient has got fever, malaise, lymphadenopathy, patient has got oral ulcer, okay, then you can think of HIV. But HIV has a lot of other manifestation, not very common. Just in 1 week, patient will present with HIV. Okay, so what is the diagnosis in this case? The diagnosis is Epstein-Barr virus. CMV is uncommon because CMV doesn't give that much of a sore throat. Hepatitis, can it be hepatitis? Unlikely. Patient doesn't have any jaundice. Ross River fever. Why it is not Ross River? Ross River fever gives a history of traveling to central or northern Queensland where they can get a mosquito bite, and then they can get this Ross River fever where main presentation is fever, definitely. Then they get a rash, maculopapular rash, and they get polyarthritis or arthralgia. And they get extreme fatigue. Okay? So extreme fatigue, fever, rash, polyarthritis, that's Ross River fever. And most of the time, they say patient went for a camping, bushing, hiking, and they ended up getting some mosquito bite. Okay? Man coming back after short trip from endemic area for only 5 days with severe jaundice, and there is a fever. On examination, you found tender liver, and it is also enlarged 5 centimeter under the costal margin. You did investigations, found very high ALT, AST, GGT, ALP. What is your likely diagnosis? So you have found a patient who came back after a short trip from an endemic area and coming with severe jaundice, fever, and tender hepatomegaly. And high ALT, AST is also there. So the questions are viral hepatitis A, hepatitis B, malaria, infectious mononucleosis, and also choledocholithiasis, which means stone in the common bile duct. So what do you think this patient will have? So if we look over here, hepatitis is the likely possibility in these patients. But before that, let's discuss a little bit about hepatitis. So we know, all of you know about hepatitis. The most importance are hepatitis A, B, and C. So A and E mainly transmit fecal-orally, right? And B and D, so B and C, that will be mainly parenteral, so IV or sexual. Okay, so definitely B and C should not be endemic. Very unusual for B and C to become endemic in an area. but hepatitis A can be endemic. Okay, so that's one clue to think of hepatitis A. Now, for any hepatitis, there is pre-icteric phase and icteric phase. In the pre-icteric phase, patient gets kind of a prodromal symptoms, which is anorexia, nausea, vomiting, fever, malaise, headache, distaste for foods and everything. And then in the icteric phase, patient starts to get the jaundice. So they get jaundice, dark urine, pale stool, and they can get tender hepatomegaly as well. One of the common cause of tender hepatomegaly is viral hepatitis. Apart from that, CCF, liver abscess can also be the cause. When we think of hepatitis, we do a liver function test and we do the hepatitis serology. In the liver function test, it will give us more idea that what type of jaundice it is. So the main thing that we look at is ALT and AST, right? So if ALT is higher than more than 5 times of normal and others are normal, then you can think of hepatocellular or viral hepatitis. So in case of hepatocellular jaundice, ALT, AST will be mainly high. And if ALP, which is alkaline phosphatase, is very high, at least more than twice normal value, that's obstructive jaundice, such as like cholangitis, or if the stone is obstructing the common bile duct. Okay, so, and all of them will have hyperbilirubinemia anyway. So we will discuss jaundice in the class and we will discuss further about it. But from these questions, you can understand that it is definitely viral hepatitis A. If it was B, then there will be a history of either sharing needles with others or maybe sexual contact with prostitute or someone. Malaria can be, but malaria coming with severe jaundice, not the commonest finding. And tender hepatomegaly is a feature of chronic malaria. Not tender, like hepatosplenomegaly is a feature of chronic malaria, not acute malaria. Malaria main presentation will be fever, which in this case patient has, but severe jaundice, tender hepatomegaly just within 5 days is not very common for malaria. Infectious mononucleosis, again, it can cause jaundice, but there is no sore throat, there is no lymphadenopathy, and nothing to do with endemic. And definitely not a CBD stone. Now, in here, it depends on in the exam, Dr. Sundas. So they will give you the specific value in the exam. And in exam, you will find out that ALP can be high, but ALT will be very high in this patient. Okay, so doesn't mean that ALP will not be a little bit high. ALP also will be a little bit high in this patient, but mainly ALT will be like 4 plus 5 plus high. So that usually in the exam, they give you a lab finding and you will definitely get something like that. Malaria present, the earliest malaria can present is 7 days. Because that's the incubation period, I think, for falciparum. Okay, moving on. You have got a patient who has got a parotid gland swelling, and the CT shows superficial lobe involvement, no facial nerve palsy. What is the most appropriate next step? So many times you get this salivary gland swelling in the exam. So in this case, they say that they have already done a CT and they found that it is involving the superficial lobe. So basically, it is not a complete question. The complete question will say that there is a parotid gland swelling, and the CT looks a bit suspicious or solid. When CT says that there might be a bit of suspicious lesion there, then what we do? The next step after CT is doing a FNAC. Let's discuss this and then we will come back to this. So there are two things that we will discuss. One is approach to the neck mass or neck lump in adult and approach to the salivary gland lump. Okay. So I don't have the link of salivary gland here. Let me just show you. So have a look on the pathway of salivary gland swelling. So if you get a patient with salivary gland swelling, the first thing that you look for, that have you found a solid mass that when you palpate, does it feel solid? Or does it feel like it's an inflammation, like patient can get sialadenitis, which means the salivary gland infection or inflammation. And in infection inflammation, patient mainly comes with a lot of pain over there. There will be redness and patient might have fever. Patient will complain that when they chew the food or when they're trying to digest the food, then the pain gets worse. Those will indicate that this is an inflammation, not anything suspicious. So when you find out that, let's say it is a suspicious solid mass on your examination, then your next step is MRI or CT. If MRI or CT shows that there is something suspicious, then you go for FNAC, which is like CT-guided FNAC. That's our step for this kind of mass. If it is inflammatory, then you don't need to go for CT. You can go for ultrasound. And depending on what you find, your management will be different. If ultrasound finds a solid mass, then you go for CT or MRI and follow the same step. If ultrasound is normal, then if you still suspect that something might be there, you can still do a CT. If the ultrasound shows that there might be a stone, then you can go for conventional sialography or MR sialography. Okay. Now remember one thing, that for salivary gland stone, if it is a parotid gland stone, then there is a different way of getting the stone. And if it is a submandibular gland stone, there is a different imaging that we do. Can anyone tell me that what is the best way of looking for a submandibular gland stone? X-ray or ultrasound? X-ray. X-ray, okay, very good. Yes, X-ray is the best because 90% cases it is radio opaque for submandibular gland stone. Exactly the opposite is parotid gland stone. For parotid gland stone, X-ray is not the best, ultrasound is best. So depending on where is the swelling, if it is parotid gland swelling, and if you think that there might be a stone in the parotid gland, then you do ultrasound. If you think the stone might be there in submandibular, then you do X-ray. Okay, does it make sense for everyone? And to repeat this, if you get a salivary gland swelling, you first look if it is an inflammation or solid mass. If it is solid mass, you do a CT MRI, and then if it is suspicious, you go for FNAC. So that's for salivary gland mass. And our question is actually about salivary gland, right? Now, there is another thing, which is approach to the neck mass or neck lump in adults. So let's have a look. This is this is a very good guideline about neck mass. Comes in exam a lot. Okay, so this is AJGP or RACGP guideline. So you would, time to time, you will always find out that RACGP will be your one of the best guideline for this kind of questions, especially medicine related questions. So if you look over here, this says that if you get a neck mass in an adult, what is the red flag that it could be a cancer? The red flag of head and neck cancer. So the red flag for head and neck cancer is if a mass is there for more than 2 weeks, recent voice change like hoarseness of voice, dysphagia or rhinophagia, so if there is difficulty swallowing or painful swallowing, if there is a ipsilateral ear pain, nasal obstruction or epistaxis, or unexplained weight loss. Any of this is there with a neck lump, you would consider possibility of a cancer. Okay, so that's risk factor is important. So first line investigation for all adult at risk of malignancy consists of CT of the neck with contrast and the FNAC. This is the first two investigation that you would do for anyone with a neck lump who has a risk factor for cancer. But between CT and FNAC, which one should come first? CT will be the first. And if CT shows something suspicious, then you do a FNAC. The only time you would do ultrasound in a neck mass if it is a pediatric patient. For pediatric patient, your initial would be ultrasound, then you go for FNAC if it is suspicious. And also, if it is a pregnant patient, ideally you would not like too much radiation, so you can also do an ultrasound in a pregnant patient. Okay? So for this question, the patient has got a parotid gland swelling, CT shows there is a lump. So the question should be like this: the CT shows there is a suspicious solid lump with a superficial lobe involvement. What will be your next step? The next step is to confirm what is this mass by a FNAC. How can we differentiate between submandibular and parotid? So parotid gland is in front of your ear, and submandibular is below your angle of the jaw. So clinically, you can easily know that which one could be the possibility. Yeah, if CT is not in the option, you can definitely go for MRI. Now, let's say both CT and MRI in the option. What would you choose? According to RACGP, they said CT. If MRI is available, then yes, definitely we can do MRI, because MRI is best for the soft tissues or organs. CT is better for solid structure. Okay, but most of the time, CT is like very much available. That's why you go for CT with contrast in this patient. So I would rather choose a CT with contrast as per the RACGP guideline. And many of those patients eventually will end up getting an MRI as well. Therapeutic guideline is not needed for you. It's for mainly for GP exams in Australia. So we mainly follow RACGP, and therapeutic guidelines also follow RACGP. Okay. So some of the things that we are confused, I will discuss it from therapeutic guideline, but you don't need to have any subscription for that. No, that's not right, Dr. G. If the mass is a thyroid mass, for any thyroid nodule, your first investigation is ultrasound, not a CT. So that's a different scenario. We discussed thyroid in detail in the endocrine system, but for thyroid, if you think a lump is there in a thyroid gland, then you do ultrasound first. Okay. Scenario of a patient with fall from the bicycle 1 week ago and a helmet fracture. No confusion, no amnesia, but patient has headache, which increases with coughing. What is the most likely diagnosis? So you have got a patient who had a fall from bicycle 1 week back, and patient ended up getting a helmet fracture. No confusion, no amnesia, but patient now having features of headache, which increases with coughing. if a patient says that headache increases with cough, what should you think? It means that there might be a bleeding happening, right? And just because of bleeding, there might be a raised intracranial pressure. Very good, Devi. So patient, if there is a headache which increases with bending forward, coughing, we would definitely look for raised ICP. Now, having that symptom puts us to think that there must be a bleeding. Either it is inside the bleeding, either it is inside the brain, or it is epidural subdural bleeding. Something is going on. Now, you can rule out subarachnoid hemorrhage because it doesn't wait for 1 week, and concussion will not have headache increasing with coughing. So rule that out as well. Now we have got intracranial hemorrhage, extradural or epidural hematoma, and subdural hematoma. So let's discuss a little bit about this. So epidural hematoma, a skull fracture from blunt trauma causes laceration of the arterial vessels, most commonly middle meningeal artery. So all of you know that, what is the epidural space, right? So dura mater, pia mater. So if this is the dura mater, if the bleeding is out of the dura mater, that's epidural. And if bleeding is inside the dura mater, that's subdural, right? For epidural hematoma, most of the time it happens because of rupture or laceration of the arterial vessel, mainly the middle meningeal artery. And it commonly happens in the temporal bone. In contrast to the subdural hematoma, a tremendous force is usually required to have this kind of laceration causing arterial bleeding. So the main thing for epidural hematoma is, you need a tremendous force. Okay, so patient will end up getting helmet fracture. So something which is a really bad kind of injury. Always remember, nothing is 100%. Many patients who gets epidural hematoma, they will have this triphagic presentation where initially they lose their consciousness, followed by a lucid interval where they become completely fine, and then they again end up getting a bad headache, and progressively they get much worse. So that's called triphagic presentation. And if you do a CT scan in that patient, you would get this kind of biconvex shaped hematoma. Okay, so that's your epidural hematoma. What about subdural? Subdural hematoma mainly happens when there is rupture of the breathing veins. The breathing veins are susceptible to rupture because brain floats freely in CSF where the venous sinuses are fixed. Now, even with a minor trauma, these veins can get bleeding. Okay, so subdural hematoma may occur even with a minor head trauma, sometimes even spontaneously. So for this, you don't need a tremendous force. So subdural hematoma mainly happens they come with headache, altered mental status. They can have all the features like hemiparesis and everything. In contrast to epidural, sometimes subdural hematoma can take months to present. Okay, now if you do a CT for that patient, you will get a crescent-shaped hematoma in that patient. So that's subdural. Now, given that we understand from this discussion that subdural happens even with a minor trauma and epidural take a very tremendous force, what do you think the diagnosis is in here? It is likely to be epidural hematoma, even though it is 1 week. Sometimes they don't present just immediately. Sometimes they don't have that triphagic presentation. Just because they don't have the classic presentation doesn't mean that it is not an epidural hematoma. Okay? So if it is intracranial hemorrhage, it will definitely not wait for 1 week. That patient will come within 24 hours. only these two hematoma can wait like for a week. Sometimes subdural can wait for months. Okay, so based on what we have read, most likely it is epidural because of this helmet fracture. If there was no helmet fracture, then you would go with subdural hematoma. Does it make sense? It is not any kind of fracture. The helmet got broken. That's right, Dr. Huda. That's the only clue. You would not get a lot of clue in the exam. You will need to find out what's the main thing in a particular question. So exam is not like they will give you everything a patient should have. Always remember that. You can only find few. And that's the real life also. In real life, we don't get every symptoms of a particular disease in a patient. We get maybe 2 or 3 symptoms and we work out, right? So that's the same for exam as well. Now, let's discuss a little bit about genetics. Important. A parent comes to you that their son has hereditary spherocytosis. They want to know that what is the chance that his siblings will also get the same disease. It's an interesting topic to understand about this genetics. So hereditary spherocytosis, is it autosomal dominant, autosomal recessive, or X-linked recessive? It is the autosomal dominant, right? So how autosomal dominant works, that's going to be the discussion today. It's important to understand genetics a little bit because questions come from here. And if you get these questions right, those questions usually carry high marks. So let's discuss the basic of genetics and try to understand. We will mainly focus on autosomal dominant and autosomal recessive today, not the X-linked. So autosomal dominant. So let's think that we have got X and Y and X and X. Now remember, this is not a X-linked disease. This X and Y doesn't necessarily mean that this is just like the sex chromosome that we are talking about. Okay, this can be just AB and AB. Okay, so don't think it is X or Y has anything to do with male or female in this autosomal dominant or autosomal recessive. Okay, so let's say this is the father and this is the mother, and we are talking about the hereditary spherocytosis dominant gene. So let's say that the father had the Y gene was defective and that carried the hereditary spherocytosis defective gene. Okay, so father and mother, when they have a child, there are 4 possibilities. So one possibility could be this X and this X. Then this X with another X. Then let's say this is Y prime. So Y prime with this X. And Y prime with another X. So these are the 4 possible children. Okay. Is this clear for everyone? So we have got 4 possible children and the child can have any of these 4 genetic patterns. Right? So if we see that this child doesn't have any defective gene, so that's normal. This child doesn't have any genetic mutation, so that's normal also. This child has 1 defective gene. For autosomal dominant, you only need 1 defective gene. for it to become a diseased child. So this is a diseased child, and this one is also a diseased child. So we find out in here that there is a possibility that 50% of the child will be diseased and 50% of the child will be disease-free. Now, that doesn't mean that is it boy or girl. Any of the boy or girl can have the disease or can be healthy. Okay? So for autosomal dominant and autosomal recessive, this boy and girl doesn't matter. Boy and girl thing comes in the X-linked cages. Okay? So in this case, 50% of the boy and girl or 50% of the son or daughter can have the disease. 50% of the son and daughter might be healthy. So if we come back to this question, we know hereditary spherocytosis is autosomal dominant, and the parents want to know what could be the chance of the next baby to get the hereditary spherocytosis. The next baby and every baby will have the same 50% chance to get the disease. Okay? Don't think that because one baby has got it, that means only 25% left. It's not that. It's about every time this parent becomes pregnant, their children will have this equal risk. So it's about percentage. So every time they will have an equal risk of 50% baby getting the disease, 50% not diseased. Now, if we talk about autosomal recessive pattern, let's say this is X and Y, this is X and X. Now, there might be different pattern in here. For autosomal recessive, you need two defective genes to become a diseased child, not one like autosomal dominant. So only time the child will be diseased if both are defective. So let's say the father carried a defective gene, so he was a carrier, and mother also carried a defective gene, and she was a carrier. And somehow they meet and they are now having a baby. So the possible children are this X and X, like X prime and X prime, and then this X prime and X, and then we have Y X prime, and then we have got this Y and X. Right? Now, if we look over here, this one doesn't have any defective gene. So that's a healthy baby. This one has one defective gene. This one has one defective gene. So these are carrier. But this one has got both defective gene. So that's the diseased one. So this is exactly how thalassemia works. So thalassemia is an autosomal recessive disease. If father is thalassemia minor and mother is also thalassemia minor, then there will be a risk that 25% of their baby might have thalassemia major. So 25% will be diseased, 50% will be carrier, and 25% will be healthy. Okay? Does it make sense? Okay? Now for exam, please make sure you remember some of the common genetic diseases. So know about some of the common autosomal dominant disease, some of the common autosomal recessive disease. Because in exam, they would give you a disease and ask you that what is the chance that the other siblings can get the same disease. Moving on to our next one. Okay. Before I discuss this one, because this one is going to make you a bit crazy, let's take a 5-minute break and then we come back with a good rested brain? Because this is a bit difficult question. All right, so let's take a 5-minute break. Today we are going to finish the class and then we are going to discuss about the course. Okay, let's do in that way. Thank you. 5-minute break, guys. All right, everyone, let's go ahead. So these was the questions we are talking about, right? So you've got a nurse who suffered needle-stick injury at your ward. She had previous hepatitis B vaccines 10 years ago with positive serology. No booster was taken after that. And patient's HIV negative, but the hepatitis B surface antigen and hepatitis C virus PCR RNA positive. What will you do next? So this kind of questions come in exam, and you need to get a very, very good idea about this prophylaxis for this kind of occupational needle injury. So I'm going to discuss in detail, not about HIV today because that's negative, but about Hep B and Hep C. So the question can come in a lot of ways, but the idea is how you are going to treat a patient who had a needle-stick injury. Now in here, your nurse is the patient. So nurse is the victim and the source is the patient. Okay. So the needle-stick injury happened for this patient, right? So the victim is the nurse who will need the treatment, and the patient status is important to know. So we need to know that if the patient already positive for some kind of blood-borne virus. So let's see how we are going to treat this patient. So there is a very good guideline about it. So that's the queensland.gov.au guideline for occupational needle-stick injury. So let's see. So now we're coming to 4.10, that's the hepatitis B virus exposure. So try to understand the basic because that's going to help you with a lot of other questions. So first of all, we want to know that what is the source status, that means in here our patient, and what is the exposed person, in here our nurse. So exposed person status and the source status is important. So if the source is known to be positive of hepatitis B virus, especially the surface antigen, or even the source status is unknown, then we want to know what is the exposed person status. If the victim has no prior history of immunization, especially for Hep B immunization, and no prior documentation of hepatitis B antibody more than 10. For a patient to be immune against hepatitis B, they need at least hepatitis B antibody more than 10. Okay, so if our victim is not immune, for that patient, post-exposure prophylaxis should be considered. But if someone has a previously documented immunity, then what we are going to do? So that's the main question, okay? Now let's have a look. So we have found a patient who was, or our victim is previously vaccinated. So we found out that the victim is vaccinated and the source is positive for hepatitis B. So if a previously vaccinated patient was a known vaccine responder, which means that at some point they were immune to hepatitis B, and currently they are immune. So when you check the hepatitis B antibody, it is coming more than 10. No treatment is needed, even if the source is positive for hepatitis B, because patient is immune or the victim is immune, right? Known vaccine responder, but currently there is no immunity. So even currently there is no immunity, but previously patient had a documentation that that he was a vaccine responder. That means at some time his hepatitis B antibody was more than 10, still there is no need of any treatment. But the patient was never a vaccine responder. That means there is no documentation of having a hepatitis B antibody more than 10. In that patient, you will need to give a hepatitis B immunoglobulin, just a single dose. Okay, so for vaccine non-responder, the only thing that you would give is hepatitis B immunoglobulin. But if someone was a vaccine responder, no need of any immunoglobulin. Does it make sense, guys? It's a bit tricky. So non-responder means that they never had a hepatitis B antibody level more than 10. Okay? Let's say you don't know if the patient was ever, like patient doesn't know about any time if he had a documented seroconversion. That means patient is not sure that if there was any time hepatitis B antibody was more than 10. If the patient is not sure, then you would check it now. And if it is more than 10, no treatment. If it is less than 10, immunoglobulin. Easy. So the main thing is that if there was a documented history that yes, patient had a hepatitis B antibody more than 10, then no treatment is needed because they are vaccine responder. But never ever they had a hepatitis B antibody more than 10, they are non-responder. So for them, immunoglobulin should be added. Let's say patient was never vaccinated. For that patient, you would give them immunoglobulin, and you will also start the hepatitis B 3-dose vaccine. All right, so that's the main thing that you need to remember from here. And also go through this table. I will just post it in here. So I will share this link in the chat box. So go to this link and you can even print it out so that you can go through it in more detailed. Okay, but there is a lot of other things, like let's say Dr. Kamal. So when you initiate the booster dose is this one. So you don't know. So you know that the patient, that means the source is negative for hepatitis B surface antigen, but the patient is vaccine non-responder. For that patient, you can start the booster dose. Okay. So booster dose usually doesn't come in exam, but the main thing you should remember from this is that when there is a needlestick injury, you look at the source, if the source is positive for hepatitis B or not. If the source is positive for hepatitis B, you look at that your victim blood. Has the victim ever been vaccinated or not? If the victim was vaccinated, was he a responder or not? If he was a responder, no treatment needed. If he was a non-responder, then you give the immunoglobulin. Simple as it is. So if you can remember in that way, it will make a lot of sense. Never been vaccinated, for that patient, you need to give both vaccine and immunoglobulin. Okay? What about hepatitis C? Because this source is also positive for hepatitis C, right? So for that patient, hepatitis C, you can't do anything. You can't give a vaccine, you can't give a immunoglobulin. So what would you do? So the idea is if the source is positive for hepatitis C, provide counseling to the victim, collect the victim's blood for baseline hepatitis C virus antibody, and also baseline liver function test. You can't give any prophylaxis which will prevent hepatitis C virus. Immunoglobulin antiviral are not recommended at that time. So what you do is that you have taken the baseline blood, and at 12 weeks, that means at 3 months and 6 months, you will do another repeat test. So you will again check if the victim has got hepatitis C virus or if there is any change in the liver function test. Okay, so in these cases, you just do the follow-up for hepatitis C virus. Now, going back to the question, you should also read HIV from this guideline because sometimes it comes in exam as well. So difference between non-responder and non-vaccinated. Non-responder, they got vaccine, but they did not get the immunity. And non-vaccinated means they have never been vaccinated. So for this patient, definitely, because in this patient, Hep B was given 10 years ago with a positive serology. That means this is a vaccine responder patient, right? So for this patient, if there was an option of no treatment, you can do it. But there is no such option in here. So the next best option would be to check the immunity level for hepatitis B for this patient. Okay. Which test should be performed? Anti-hepatitis C virus or hepatitis C virus RNA PCR? So you check the antibody first. If antibody comes positive, then you do the PCR. All right, guys, any questions with this topic? Positive serology means they got the immunity. Yeah. So positive serology means that they were a responder. So for this particular patient, according to our discussion, patient doesn't need any treatment because she was a vaccine responder. Okay. So definitely for that patient, no need of any treatment, except you would check the hepatitis C virus baseline if there was no option in here. So for hepatitis B, nothing needs to be done actually. For hepatitis C, you could do a baseline hepatitis C virus antibody and checking the ALT in this case, and then in 3 months and 6 months. But that's not in the option as well. So out of these 4 options, the best option to check if the victim is immune or not. Dr. Neary, I'm not going to discuss the HIV at the moment because we want to do some others, but you can always go through that guideline. Moving on to a lady comes to you with weakness of lower limbs. She drags her foot while walking. Dorsiflexion and plantar flexion is weak. Reflexes are exaggerated. Equivocal plantar response. What is the diagnosis? So have a look on this question. A lady comes to you with weakness of lower limbs. So let's say that both lower limb has got weakness. She drags her foot while walking, so dragging. Dorsiflexion, plantar flexion is weak, but the reflex is exaggerated. And on the other hand, plantar response is equivocal. Now, this is a very tricky question. So when we do the neurology class, we will discuss further about this, but this is a case of motor neuron disease. So motor neuron disease is a condition where only the motor nerves will be involved, no sensory problem, such as in this case, there is no sensation problem. So patient with motor neuron disease, there are several subtypes. So there are subtypes which is amyotrophic lateral sclerosis, where you get a combination of both upper motor neuron and lower motor neuron type of palsy. There are other subtypes where you can get only upper motor and only lower motor. But the commonest one is the combination. So normally I say that in a patient, if you get a combined symptoms or sign of upper motor and lower motor, think about motor neuron disease. Let's have a look at what are upper motor and lower motor. So upper motor neuron means that anything is starting from the cerebral cortex. Then you have got the anterior horn cell of the spinal cord, right? So the corticospinal tract, let's say. So any neural tract which starts from the cerebral cortex and then it gets synapsed with the anterior horn cell of the spinal cord, and from there it goes to the target organs or target muscles. So up to this is upper motor neuron, and after anterior horn cell of the spinal cord, you have got lower motor neuron. We will discuss this in much more detailed way in neurology class. But upper motor neuron symptoms mainly present with spasticity, whereas lower motor neuron mainly comes with flaccid paraplegia. So it becomes flaccid weakness, whereas upper motor is spastic weakness. Fasciculation is absent in upper motor, whereas it is present in lower motor. Hyperreflexia is upper motor, and lower motor you get hyporeflexia. And also if you do the plantar response will be extensor in upper motor and equivocal or flexor in lower motor. Okay, so that's usually the common signs that we look for in this upper and lower motor neuron palsy. If you look on this question, you can definitely see that this patient has got exaggerated reflex. So that's a feature of upper motor neuron. Whereas equivocal plantar response, which is lower motor neuron, they haven't said like explicitly that it is like a spastic or flaccid weakness, but even if they haven't, just by these two things, we know that there is a combination of upper and lower motor in this patient. So depending on that, we can easily decide that it is motor neuron disease. So how we can exclude the others? So first of all, they are asking about the diagnosis. Can we choose lesion in the cerebral cortex as our diagnosis? No. If the option was, where is the lesion? Okay. So if the question was, where is the lesion? Then we could choose lesion in the cerebral cortex. But when they ask the diagnosis, we should choose the main diagnosis. Now let's talk about cervical spine myelopathy. Okay, now in here there is no myelopathy, there is cervical spine multiple sclerosis. Multiple sclerosis mainly gives only upper motor neuron type of symptom. Okay, and if it is a cervical spine which has got involved, where exactly the symptom should be? Guys, if you know about the neurological, the dermatomes and everything, cervical spine, the nerve that comes out, C5, C6, C7, all of them, it mainly supplies the upper limbs. So if there is any cervical problem, the symptom should be in the upper limb, not in the lower limb. And I'm sure Dr. Shia, the one that is in the handbook, the patient must have some symptoms in the upper limb. Okay? So same with the cervical myelopathy. Myelopathy is the spinal cord compression in the cervical spine. Okay, so if the spinal cord is compressed in the cervical spine, then again the symptoms should be there in the upper limb, and then it can go to the lower limb. But upper limb should be involved if there is any problem in the cervical spine. Okay, if there is no involvement of the upper limb, we can't think of any issues in the cervical spine. Okay. Same with the spinal canal stenosis. It only gives upper motor neuron type of symptoms, not lower motor. So even if we just do the exclusion of the option, still your diagnosis will come as motor neuron disease. What is lumbar spondylosis? Spondylosis is just a degeneration in the vertebra. Just because of degeneration, patient will not have, like, doesn't matter, right? So spondylosis will not give us neurological symptom unless it starts to compress the spinal cord or the foramen. Okay? And same, I don't know what's your name, who you are asking. Your name is showing as iPhone 13. You're asking about lumbar myelopathy. So same, myelopathy always will come as upper motor neuron type of palsy below the level of lesion. So it will not be a combination of both. So at the level of the stenosis or at the level of compression, you get lower motor neuron type of feature. Below the level of the lesion, you get upper motor neuron type of feature. Now, have a look on this question. 58 years old man dragging the left foot, reflex on the left foot limb. Dr. Neerlody, how number 4 was excluded? Lesion in the cervical cortex. It's just because it can be a lesion in the cervical cortex, but they asked about the diagnosis. Is it a diagnosis, lesion in the cervical cortex, Dr. Neerlody? It's not a diagnosis. Cervical cortex lesion can be like lots of diseases can be there in the cervical cortex. So that's not a disease. 58 years old man, dragging left foot, reflexes on the left lower limb are increased, plantar flexion, dorsiflexion 4/5, weak ankle movement, equivocal plantar reflex, upper limb face normal. What is the lesion site? Now, if you look over here, this is the question. They're asking about the lesion site. So again, dragging left foot, left lower limb reflex increased, plantar and dorsiflexion weak, but equivocal plantar reflex. It is the same thing, same question in a different way, but they're asking about the lesion site. So that's where you will say the lesion site is cerebral cortex. Okay? Because this is also motor neuron disease because patient has got both upper motor and lower motor neuron type of feature. So most of these will be cerebral cortex which has got involved because that's where your most of the motor neurons are. All right. So if they are asking about the lesion site, then you say where is the lesion? Why not it is brainstem? Because brainstem also has motor neuron. Because if it was brainstem, you would get brainstem feature, which is diplopia, nystagmus, vertigo. Those symptoms will be there. Okay. You must be thinking that the cerebral cortex has got involved, but face, upper limb has no problem. Why only the lower limb? Because this is called homunculus. In your brain, there is a specific part which mainly like works for a specific portion. Like this part of the brain works for your face, this part for your arm, this part for your legs. So if the cerebral cortex motor neuron is affected just only here, only finding will be in the lower limb, not in the upper limb or face. Okay? So it doesn't mean that just because cerebral cortex is involved, everything will be involved at the same time. All right, guys. So I was intending to discuss a lot of other things, but our time is up. That's fine. We will be discussing a lot of other questions throughout the course. And that's our end of the today's session. I hope you guys enjoyed it. I hope you learned how the exam questions can be. But I'm going to discuss a little bit about the course because this is a free sessions and it's for everyone to learn about the course. So I'll take the opportunity to go through the course. And if you guys have any questions, feel free to ask me now. So we discuss this time to time. So for First Aid AMC 5 months course it started today. It's for everyone. So this is a free 2-week session, but the course has started from today. So this is the first class, but even the trial class that we have taken on 27th, that was a part of the course as well. So the new batch trial class has been done. We have provided the recording of that class in your Facebook group. So if anyone missed, you can go through it. Just write recording in the search box of our First Aid AMC MCQ Facebook group, and you should be able to find out all the recordings. You have already got the schedule for these 2-week sessions. The Zoom ID and everything will be similar, so just join according to the schedule. The course is designed in a way so that it covers everything that you need. As you can see, even during the question solve, we try to include as much theory as possible, but make sure that if you want to learn more questions, you have to give us time to get forward, because if we get a lot of questions, we will try our best to answer it. And when we answer it, we lose the time. But that's how it is. Initially, everyone do that, but eventually, I would hope that you will give us more time to discuss these things in the theory classes and get more and more questions solved in the question solve classes rather than theory discussion. So full theory discussions will be done in the course. 5-year sample question discussion, which means any questions that we have discussed from 2018, it's already in the portal. And definitely we discuss mainly the 2024 one in the class. We give you 1 to 2 class every week just for question solve. And then there are 2 theory classes in a week. So most of the time you get 3 classes, sometimes 4 class in a week. Software-based subjective test, month-wise test, and also full 150 question mock test are available. You get a QBank, access to the course until you pass. Recording will be there with the extended video recording even after finishing the course. So fee is $499 plus 10% GST. So the math becomes 548 Australian dollar. The course is 5 months duration, and the classes are mainly on Friday, Saturday, and Tuesday. Class time is 7:30 to 9:30 p.m. Sydney time at the moment, but from October it will be changed to 8:30. So we discussed complete theory based on John Murtagh, Kaplan-Meier 2, and some other guideline. We always have theory-based question discussion as well. So we do, let's say, psychiatry, and then after the whole psychiatry class, we do a psychiatry question solve. You get a mock test based on the theory in your portal. 5-year question discussion, as we said, and you also get mock test on those monthly questions that we discuss. And lots of mock tests are there. So we add recent ongoing mock test. Even if you finish the course, you will get access to the new mock test that we upload. Okay. We take extra classes on anything that comes in exam. So don't worry on the ECG, CT, X-ray, CTG stat. So I don't think anyone needs anything after the course, because it's been well structured. We are doing it for years and years, so nothing is actually left. So all you need to do is to go through the guideline, go through the classes, and finish what we want you to finish. Okay. So you can go through this. And also we have our website here. So if you write firstaidamc.com, you can also read everything there. There is an email address. If you want to get enrolled, I would definitely say this is the time to start the process, because we do your identity verification and everything. So it takes a while for you to get added. So please don't wait for the last few days to get added to the course, because we would not be able to add you to the course just within 1 or 2 days after you make the payment. So there is a 1-week waiting time to get added to the portal, to get added to the course, even after you make the payment. Okay. So please make sure you start the process if you are interested. This is recorded? Yes, it is recorded and it will be uploaded. Are the theory lectures from 2021? No, Dr. Shavir, I don't know why it will be 2021. The theory lectures are updated always because 2021 we used to do JM 7th edition. Now there is JM 8th edition. So as the edition changes, our course also changes. We're still updating videos, Dr. N. So you have to give us a bit of time to upload all the videos. You can pay any time to join the course, okay, Dr. Kanja. There is a Telegram group for the course student. Once this 2-week session is over, then we will start to add you there. Yes, so all the classes that we take, the PDF file will be uploaded in the portal. What do you mean by the placement, Dr. Tamanna, after AMC first step? So after you do the first step, you can either do your English and then apply for the job, or you can prepare for AMC Part 2. This session will be uploaded in your portal and also in the YouTube. Is it okay to study for 2026? 2026 is a long time ahead. I would say maybe start from 2025, but everything is fine. If you need a little bit more time to prepare, that's fine. Many people take 1 year to prepare, but 6 months is enough to prepare for this exam if you give enough time. There is no WhatsApp group, but if you guys want, you can always make one. Yes, we will. So this is what we have. The question solve classes are the recalls, okay? Dr. Sadia and Enz. So we do those question solve classes. That's what's the main questions that's important for your exam. So as we have done today, and also when you see the recent question solve classes, those are question solve classes. You don't need to subscribe for any QBank except the course. And Dr. Nabil, recommended books, we have uploaded a post in your Facebook course group about the recommended books for this AMC preparation. So if you're part of the course, definitely you will be added to the course group and you can read those guidelines there. QBank, we don't recommend any QBank, but if you are interested, you can go through any of the available ones. So CPD hours depend. So the classes that I take will be you can add it in the CPD. That will be like if you are a member of any of the RACGP or ACRAM colleges. How many mock tests are there? There is no count. There is a numerous amount of mock tests, and every month we add new mock test. Okay, so don't worry about mock tests. It's not just 5 or 10 mock tests. There are more than 40 mock tests in the portal. The next class, the class schedule has been uploaded, Dr. Abiha. So if anyone didn't know, so if you go to the first aid AMC MCQ, you can see all of our posts here, and this is where you can get our class schedule. So if you are part of first aid AMC MCQ, you can easily go through everything. And Dr. Anika, a lot of our students do offline recording, right? So if your time doesn't match, these are video recordings. So it means that it is exactly the same like the live class. So more than half of our students do just the recorded classes. So it's not you only, but we always encourage people to do the live session because you have the opportunity to ask questions. So time to time try to come in the live session, but it's totally fine. If you can't match the time, just go through the recorded class. Yes, your portal will be up to that, Dr. Shruti. So your portal will be open until you pass the exam. So our question solve classes are taken by different mentors. You will get classes from them as well. I can't say the fourth class which day will be. That will be given to you as a schedule. How to get access? So once you make the payment, Dr. Mohitos, let us know, and then we will inform you how to get access. I would definitely say no, do not quit your job, because yes, as other doctor says, recency matters. So even if you can lower down your job stress, maybe 2 or 3 days a week, but keep your job, please. Next batch will be in January next year. And Dr. Shabir, there should be videos of 2023. When we do a orientation class, then we will show you how to go through the portal. And we have already added a video where to find what. So if you are added to the first aid course group, then go through that video of portal. You might be able to find out how to pay. Just send me a message or an email. Experience has a profit, Dr. Tamanna. We are not discussing about the pathway of registration today. There will be a class or a session on that. So please wait for that. How much time for pesky preparation? There is no time anyone can give you, Dr. Urmi. So many people take 6 months. So ideally 6 months is better. Payment method is by your bank card. So Visa or MasterCard will be the best approach. How to pay the fee? So Dr. Abdullah, you just need to send, either you can, so if you go to Facebook, if you just find my profile and send me a message, or you send us an email. So you can easily find our email in any of these posts. So at the bottom of it. So just send us an email in here that you want to make payment. Then we will send you an invoice. And then with the invoice, you'll be able to make the payment. Yes, so portal just it doesn't only have notes, it also have video recordings of previous batch. So if anyone have time, yes, just go ahead and go through them. Totally fine. Email address should not be invalid. See if there is anything wrong has been done, Dr. Dina. If it is wrong, then try just sending me a message. We can also sort you out. Last day, there is no last date for enrolling the class. Many people join our course in the middle, but we always recommend to join just now, because in that way you can easily get oriented with our course rather than joining in the middle. If there is no video lecture in your portal, send me a message saying that you have been added, but you are not getting the video lecture. We will sort it out. You can use cell phone for the portal, but laptop is ideal. Cell phone, you will not get the best experience. And anyone who made the payment, as we have already said in our email, like you must have got it. So it can take a week to get added. So if you have paid on 7th, it's just 3 days. So it's not uncommon not to get added, Dr. Mohitos, but you can always send us the email again that you're waiting for the approval. Yes, so no one needs to record. You would not be able to record these classes anyway. So everything will be uploaded in the portal and you can go through them. Course fee is $499 Australian dollar plus 10% GST, which is $548. So, Dr. Vinay, so this is where you can see. So this is all the class schedule for now. So tips and tricks to solve MCQ. This is one of the question solve class that we have taken today. 17th and 19th, there will be further question solve classes. That's not right, Dr. Shabir. So PDF files are not from 2021. It shows there, like you might see there that it's 2021 because it was uploaded on the first time in 2021, but since then it has been changed and edited. That doesn't show in the portal. Please don't get confused with that, okay? This is not anything confusing, as I have already told you. And also, like you just started the course, so we are still adding the videos in the portal. So there are lots of videos already. Try to finish them in between. So it doesn't matter if we even add all the videos just now, you will need a lot of time. People take 5 months to finish these classes. So wait a little bit for us to finish uploading, but there are lots already. Try to start them and finish first. If you start preparation now, can you go for exam in November? It's totally up to you. I would not recommend if you are if you are just like a new candidate, you haven't started your preparation yet, because you will only have September, October, November. So 3 months is not enough for preparation. So definitely no. But if you're in the middle of your preparation, then you can try. Do you need to make a full payment? Yes, there is no two installment for MCQ. You have to pay full in advance. Yes, we can add that, Dr. Samin. So the step 2 seek a notes, right? Okay, that's fine. We can upload that as well if it's not opening. Psychiatry, no. There will be further classes on psychiatry. You can't use two devices at a time. You can only use one device at a time in the portal. How many hours do we need to study? I say at least 4 to 6 hours if you can. That's the best. Okay. All right. So let's finish it here tonight, guys. There will be a lot of questions. You can always ask me in the next classes. Let's finish it here. And if there is anyone in here who has made the payment and you have waited for more than a week to get added to the portal, please send an email or send me a message. Okay, we'll sort it out. This is the time where we are also trying our best to make sure everyone gets added, but there is a lot of students who get added in this time. So please keep your patience, because we are trying our best to make sure you get the best experience. But we also need some time to do all of this. And Saturday, Sunday is a public holiday here. So definitely we don't work, like our team doesn't work on that 2 days. So give us some time. That's all we are asking. Okay. Dr. Nabil, if you are going for middle of 2025, then start joining now. Don't wait for January. Because many times what I say, that you finish the course for 5 months, so it will be finished in, like, let's say late December or early January. then you would need some time to revise everything. So many of you will go for exam in March, April. Okay. So if you are planning for June, July, still I would definitely say join this course now. Don't wait for January. It's just not a good idea. Thank you, Dr. Shabir. Okay. All right, guys. So let's finish it here tonight, and we'll talk again in the next class. Thanks, guys. Take care. Bye.